Hello class, Professor Van Dusen here. Today we're going to talk about anxiety disorders in this lecture. Our outcomes for today, after this lecture you'll be able to differentiate normal anxiety responses from those suggested of an anxiety disorder, identify indicators of the 4 levels of anxiety and nursing interventions that are appropriate for each of those levels, and describe the prevalence and incidence of different anxiety disorders. So let's talk about an overview of anxiety disorders. This is the most common psychiatric illness. It's chronic and it is persistent. Women experience anxiety disorders more often than men do, and it's often in association with other mental and physical comorbidities such as depression, heart disease, sometimes respiratory disease, many of these things that can kind of cause anxiety. It's the most common condition in adolescence, and its prevalence actually decreases with age. So as people get older, their anxiety levels decrease. And why do you think that might be? Part of the reason why that is life experience, right? So as people get older and they have more life experiences, their anxiety levels decrease. Um, and simply because they just have a better anticipation of what's going to happen or better perceptions of the world, um, and so on. So factors that determine whether an anxiety is a symptom of a mental disorder. So everyone has a little bit of anxiety, and some anxiety is normal. You should have some anxiety before you have one of your nursing exams, for example. But the intensity of the anxiety relative to the situation is kind of how we determine whether or not this is going to be a disorder. And what is the trigger for the anxiety? Is it something that is perceived as a normal trigger for anxiety? There are 4 levels or 4 degrees of anxiety. There's mild, moderate, severe, and panic. We will go over in class what these 4 levels are, nursing interventions for each, and how to identify if your patient is having a mild level of anxiety versus severe or a panic attack. There's different defense mechanisms people use to reduce their anxiety. And so this helps prevent or diminish unwanted thoughts and feelings. This may be helpful, but it can be problematic if they're overused. So it's important to identify the use of a defense mechanism that someone is using and determine whether it's healthy or unhealthy for that person. So what is working for one person may not be working for another. For example, denial is a very common defense mechanism. So where someone might be in denial that their house is a mess, and so they're putting off cleaning it because it causes them anxiety, and that might not be detrimental to that person's health, um, that might be okay for now for that person. But somebody else who maybe, let's say they just had a CAT scan and the CAT scan showed that they have some nodules on their lungs, and it's recommended that they need to follow up with a pulmonologist to make sure that they have um, non-cancerous nodules. And that person says, no, I'm not going to do any follow-up. I'm fine. There's nothing going on with those nodules. That could be detrimental to that person's health. That denial is unhealthy, and that really isn't going to work for that person, and that's something that we might need to intervene. Some different types of defense mechanisms, and this is an excerpt from your book. So there's repression, denial, projection, displacement, regression, and sublimation. And these are just some of, they're not all of the defense mechanisms, but they are some common ones. So repression is an unconscious mechanism employed by the ego to keep disturbing or threatening thoughts from becoming conscious. So we repress those thoughts, like we try not to think about them. Denial involves blocking external events from our awareness, so we just try to not even think about it. The situation's just too much to handle, so the person refuses to experience it. Projection involves when individuals attribute their own unacceptable thoughts, feelings, and motives to another person. So projecting those thoughts onto someone else. Displacement is satisfying an impulse with a substitute object. Um, that could be like someone who's really frustrated punches a wall, or they're mad at their boss and they go home and they kick their dog. That's the example that they give here in your book. Regression is a movement back to a psychological time when someone's faced with stress. And I think we know about this with childhood regression. A child may start to suck their thumb again or wet the bed um, when they spend too much time in the hospital, and that would be an example of regression. Sublimation is satisfying an impulse with a substitute object in a socially acceptable way. So, like a sport is an example of putting our emotions or aggression into something constructive. So, somebody who's really mad or upset maybe put that emotions and energy into playing football, for example. So, talking about anxiety across the lifespan, um, prompt identification, diagnosis, and treatment may be difficult in special populations, but if left untreated in children and adolescents, these symptoms can persist and gradually worsen, and sometimes lead to separation anxiety and or mutism. Um, Suicidal ideation or suicide attempts, of course, are very important to watch out for. Early parenthood, for teen pregnancies, drug and alcohol dependence, and educational underachievement later in life. As we move into older adult populations, the rates of anxiety disorders are just as high as mood disorders. And this combination of depressive and anxiety symptoms can lead to a decrease in social functioning, an increase in those somatic symptoms, those physical symptoms like stomach aches, headaches, and unexplained aches and pains, and an increase in depressive symptoms. Because our older population is at high risk for suicide, there's special assessments of anxiety symptoms is really essential. Detecting and treating anxiety is really an important component of pain management. People with high levels of anxiety experience a lot of pain, and sometimes that's a vicious cycle. They're anxious because they're in pain because they're anxious, and if we can bring their anxiety levels down, it will also bring their pain levels down to a manageable level. So moving right into panic disorder. So we're going to that last level of our 4 levels of anxiety and talking about panic disorder specifically. People have panic attacks. So what is a panic disorder? When does this become true panic disorder? So this is an extreme and overwhelming form of anxiety that's often experienced when an individual is placed in a real or perceived life-threatening situation. So panic is normal during periods of threat, but it's abnormal when it's continuously experienced in a situation where there's no real physical or psychological threat, right? So let's say there was a shooter on campus and we were very filled with anxiety and some people started to panic. That would be a normal situation where a panic would be kind of an acceptable experience. Now, let's say there was um, something else, a dog comes into the classroom and someone has a severe panic attack uh, for whatever reason. That may not be considered socially, normal situation where panic would occur. And in that case, that person may have a panic disorder based on a perceived threat, and that would be a trigger for them. So the onset of panic disorders can typically occur during puberty, highest onsets in persons in their 20s, and again, we're talking about mental health challenges that occur in people in their late teens to early 20s. We have the hormones surging and responsibilities are suddenly creeping in. People having to pay rent, maybe moving out of their parents' homes, going to college for the first time, balancing their financial responsibilities with their schoolwork. This can become very overwhelming for people and can cause some of these triggers with the heightened anxiety. So, some typical symptoms that we see, these physical symptoms that people have when they're having an anxiety attack, these include heart palpitations and chest discomfort, a rapid pulse. They might be nauseous and dizzy. They're sweating. They could be trembling and shaking. They feel like they can't breathe and they have a shortness of breath. Sometimes they feel like their throat is closing. Sometimes the dizziness is in response to hyperventilation, like they're hyperventilating and taking really short, shallow breaths, and then they start to get some burning and prickling on their skin and their fingers and toes. It's distal, not getting enough distal oxygenation. And so these are very typical with cardiac symptoms. So sometimes they come in and they think they're having a heart attack. And it's very difficult sometimes to convince them that they are not having a cardiac event once they have a cardiac workup. So because these symptoms are similar to cardiac emergencies, the first thing that we really need to do is get an EKG, get some baseline labs, do a cardiac workup to make sure that they are not indeed having a cardiac event. Um, and then, try to do the best we can to comfort them. Sometimes, they remain unconvinced that it's a panic attack even after we tell them that the cardiac workup is negative. And these symptoms are physically taxing, they're psychologically frightening to the person, and they become very exhausted sometimes after these panic attacks. Cognitive symptoms, so those are physical symptoms, right? So they're sweating, they're shaking, they're short of breath. Now we're going to talk about some of these cognitive symptoms, like what are they thinking? They may be having some very disorganized thinking, irrational fears, like, someone's going to jump out of the closet at them, or something might be under the bed. Depersonalization, feeling like they're losing control. Poor communication, they're really having trouble telling you what is happening with them. A lot of times they explain that it feels like there's impending doom or death, or they feel like they're going crazy or losing control, and they feel desperate, like this desperation ensues. So these are very typical, common cognitive symptoms that someone is experiencing while having a panic attack. So you can imagine how exhausting this might be for someone and how scary it might be for them as well. And they're going to have a lot of difficulty listening to you while you're trying to give them direction, if you're trying to get them to take deep breaths, if you're trying to ask them even to sit down or collect their past medical history and all of that information. It may be very difficult for them to concentrate to get that information from them or to give them directions. They're certainly not going to be able to take any new education at that time and really comprehend what you're saying. So a panic attack is a surge intense of fear or discomfort that reaches its peak within minutes, during which four or more of the following symptoms occur. So there's palpitations, nausea, abdominal distress, sweating, sensations of choking, chest pain, shaking, shortness of breath or smothering, dizziness, the derealization or depersonalization, fear of going crazy, fear of dying, paresthesia, chills or hot flashes. Okay, so this is the diagnostic criteria. This is a chronic condition with several exacerbations and remission during the course of the disease. This can happen for years. Maybe this person could have one panic attack and then not have any for many years, and then a trigger comes along and they have another one. The epidemiology is typically females more than males, middle-aged, people of low socioeconomic status, people who are widowed or more at risk, separated or divorced. Other risk factors include family history of panic disorder, substance and stimulant use or abuse, smoking tobacco, because that is a stimulant, um, and other severe stressors like life and environmental and personal stressors. Comorbidities can be other anxiety disorders, depression, eating disorders sometimes, substance abuse, schizophrenia, ethnicity and culture. So this is experienced differently across different racial and ethnic groups, and we'll talk more about that in class. So working towards recovery, how are we going to treat someone having a panic attack or having panic disorder? So cognitive behavioral therapy really helps people change their perception of whatever is triggering them so that maybe they can better cope with that experience and that memory so that they can have a more positive outlook and a better coping experience and maybe reduce the amount of panic attacks that they're going to have or those panic symptoms. Individual therapy or group therapy, depending on the person's preference. Exposure therapy sometimes. Systematic desensitization helps. If someone has a panic attack, when they have panic attacks, sometimes can go hand in hand with phobias. So if someone is afraid of snakes and they see the snake and it hurls them into a panic attack, um, a good treatment option, a really effective one, would be to expose someone to snakes in a very controlled environment, starting maybe with a stuffed animal and then a video of a live snake, um, progressing into um, maybe a toy or one of those rubber snakes, and then possibly like a dead but real snake, and then maybe a real snake in a museum or wherever, zoo or something, and you kind of work up to that moment where you can handle being with the real objects. And that is systematic desensitization, and that's a really popular exposure therapy technique for many different mental health challenges that um, produce very severe symptoms to help bring those symptoms down. So different pharmacological interventions. Our SSRIs are most commonly prescribed for panic disorder, and that just kind of helps with that, butterfly in your stomach kind of feeling on a regular basis. So that's something they're going to take every day, and that's going to help reduce the triggers and the feelings that they have when the triggers come. And then certainly a benzodiazepine, something like Ativan, would be acceptable to prescribe, but something that they would take when they know a panic attack is happening. So they feel that anxiety coming on, they've been exposed to a situation that's caused them to trigger, and then they would take the benzodiazepine at that time, but it's certainly not something they would take every day. So our goals for treatment, a lot of times we're going to want to have these SMART goals, the specific, measurable, obtainable, relevant, and time-bound goals. Um, our therapeutic interactions are very important. We can provide distraction, maybe some reframing of the events that are, thoughts in their mind, to reframe those thoughts into more positive ones. Positive self-talk, psychoeducation, which is talk therapy, different wellness strategies. Time management is always a really common thing to help reduce anxiety in general. I'm sure when you are running late to class and you're driving as fast as you can to get to the campus, and then you park your car and you're speed walking into class and you get to your seat and you're taking out all your stuff, it's very anxiety provoking, and you can feel your anxiety levels rise. And then if something triggers on top of that, it's just going to be enough to kind of put you over the edge. So good time management to begin with can really help reduce those levels of anxiety. Coordination with primary care providers. Primary care providers are going to treat the physical symptoms. Our psychiatrists are not going to be treating the stomach aches and the headaches and the other physical pains, aches and pains. Anxiety can be caused by physical health issues, so it's important to have that physical assessment done to make sure that there's nothing going on with the body that's causing the anxiety. Sometimes people, anxiety and depression are caused by these chronic pain conditions. Sometimes anxiety can be the side effect of prescription or non-prescription drugs, especially if it's a stimulant. And sometimes this can prevent misdiagnosis or wrong treatment if we can have our primary health care providers involved in the treatment process. So our first priority is always going to be suicide prevention if this patient indicates that they are suicidal. If they say that they have a suicidal ideation or a plan, that always goes to the top of your priority list for assessments, okay? If not, then our first priority is our physical assessment because we want to make sure that there's nothing physically wrong with the patient that's causing their psychological issues. And then we can move on to a mental health assessment. So, important things to note: establish trust with your client, whether that's saying that you're going to get them something and come back when you do, maintaining eye contact if culturally appropriate, using their name when you talk to them just so that they know that you know who they are. That all establishes trust with your clients. Decrease environmental stimulation and limit peer interactions. This may be just turning off the TV or turning off the radio in their room, closing the curtains if there's a lot of traffic going by outside. Do not criticize the client's coping techniques. If they have a blanket that they want to keep up next to their face, or they have a stress ball that they're using, or they have a special pair of socks that make them feel comfortable and grounded, do not criticize. Whatever makes them feel like they are coping well, as long as it is a healthy coping technique that is not going to harm them. Always remain with the client. You can walk or pace with them. If they feel like they cannot sit down because they are just too full of energy, do not try to make them sit in a chair or on a bed or in the corner, but walk with them. Take a walk. Let them pace back and forth and pace with them so that you can find out what their needs are and let them expel some of that energy as long as they're doing it in a safe or healthy way. Provide clear and simple statements. So if you want them to come to their room because you want to have a private discussion with them, you might just need to say, "Sir, I need you to come to your room." And just be very simple and clear. Not big, long explanations because they're not going to hear you. There's too much going on in their heads cognitively. Provide a therapeutic environment and relationship, and that just kind of ties in with everything else we discussed before. Administer PRN anxiolytic medications, so this is probably going to be your benzodiazepines like Valium or Ativan. Afterwards, allow the patient to vent his or her feelings. What caused this panic attack? What caused their anxiety to get so high? Let them tell you about it, and it may make them feel better. Assist the patient to an environment with minimal stimulation. You may need to just move them to another room that has a more calming environment. Moving on to generalized anxiety disorder. So the diagnostic criteria for generalized anxiety disorder is an excessive worry and anxiety for at least 6 months. And we're talking about everyday worrying about not just worrying about finances and worrying about, you know, things that most people worry about, but these people worry about other things too, like if driving in the car, worrying about the car is going to crash, worrying that the stove is going to catch on fire, worrying that the toilet's going to overflow, like worrying that the washing machine's going to break, like all the time, just constantly worrying about things that are probably not going to happen, very unlikely to happen, but it causes them a great deal of anxiety. And this goes on for at least 6 months before they can be diagnosed with a general anxiety disorder. The person has very little or no control over their worrying, and it significantly impairs their daily personal and social life. No one really knows what brings this on. Many complain about being chronic worriers. It's something that's just been with them their whole life. They've always had a great deal of worry, and then suddenly this just overtakes their daily lives. It affects individuals of all ages. Um, More than half is typically onset in childhood and adolescence, so it starts kind of earlier than we see in our other disorders start in 20s, age 20s. This typically starts in childhood and adolescence. It's highly somatic, so there's a great deal of focus on physical symptoms, like worrying about our physical health, um, aches and pains, worrying that things are exaggerating diagnoses based on symptoms, experiencing poor sleep habits, irritability, trembling, twitching, poor concentration, and an exaggerated startle response. Very on edge. Our priority of nursing care is very similar to panic disorders. So calm, short directions. Medications are going to be the same, those antidepressants to help kind of bring down that everyday feeling of butterflies in their stomach, anxiety, and worry. Anti-anxiety medications like benzodiazepines, perhaps for when they think that things are getting really out of hand, and those would be PRN. Nursing interventions focus on helping the person target specific areas of anxiety and reducing the impact of their anxiety. So the most important thing to remember about that generalized anxiety disorder is that in order for it to be diagnosed, they have to have chronic worrying and anxiety for at least 6 months. And that kind of goes hand in hand. Moving on to phobias. A phobia is an irrational fear of an object, person, or situation that leads to a compelling avoidance. A development of a phobia may be the outcome of extreme anxiety. And like I said in the example I used a little while ago about someone having a phobia of snakes, and it causes them extreme anxiety. So this is often present in anxiety disorders, and it may develop into a specific phobia disorder. So sometimes it can be just general phobias, but could be a very specific phobia as well, whether it's for a specific thing or a social event. So this is a persistent fear of a clearly discernible, circumscribed object or situation leading to an avoidance behavior, which means the person can tell you exactly what it is that they're afraid of. It's not like they're just generally afraid and have no idea why. They can tell you exactly what they're afraid of. The best thing for this person is an anxiolytic for short-term relief of anxiety, so probably a benzodiazepine, especially if they know they're going to be exposed to their phobia ahead of time. Exposure therapy is the treatment of choice for phobias. So if this is someone who is coming to their therapist and saying, I have a phobia of this and it's impacting my daily life, the best treatment for them is going to be exposure therapy. On this slide, I have a list of some common phobias. I'm not going to go over them all. It's an excerpt from your book, just to give you an idea of some phobias that people have. Moving on to social anxiety disorder. What is a social anxiety disorder? This is someone who has an extreme amount of anxiety when they're in a situation where they have to be social. This could be going on dates, talking to strangers, eating out in public, attending parties, or starting conversations. And this is a persistent fear of social or performance situations in which embarrassment might occur, and they go to great lengths to avoid these situations. They experience fear related to most social situations, including public performances and social interactions. Treatments for this might be the SSRIs, and this would help with that everyday feeling, right? So bringing down some of that anxiety level to begin with, to reduce the social anxiety and phobic avoidance. And then benzodiazepines for acute management to reduce anxiety prior to an event. So, say someone has an office job and there's going to be a work party at the end of the workday today that they're pretty much mandated to go to. Um, they might want to take an Ativan an hour before that work party to help bring down all of that anxiety and um, phobic avoidance so that they can actually go to that party and cope with their feelings of social anxiety disorder. And that is the end of our lecture for our anxiety disorders.